we have few questions in our mind and from several issues. Like, first of all, if you don't mind, we can have a discussion on that. Dr.
Absolutely
Sarkar?
fine.
Yes,
Absolutely
yes.
fine.
Okay, okay. So first of all, till now, if I consider, there are only two countries which have eliminated malaria as per WHO malaria free area countries, like China and El Salvador, according to my knowledge, if I'm not wrong. So where the Indian policy lies behind the China, or why China has eliminated, but India have not done it? So what's your opinion?
See, first of all, there are, as I mentioned earlier, almost 40 countries have eliminated malaria globally. And if you see the malaria map, Sir Richard Peacham had written a very nice paper several years back, syncing the malaria map globally. And that highlights how investments to eliminate malaria has helped various different countries. Now, we have seen in recent years among our neighboring countries, Sri Lanka and China have eliminated malaria. However, if you see China's progress, for a very long period, China was having very less number of malaria cases. They focused on a 1-3-7 strategy. So the basis of that, or the foundation of that strategy, lies in the fact that you know the accurate burden of malaria, you know where exactly the case is happening, where the malaria foci exist, you are investigating those foci, and you are coming up with your response within 7 days. As I mentioned earlier, currently in our country, there is no decision tool to enable such level of programming. However, India's policy has enabled several changes in the last decade. First of all, we have introduced point of care testing through rapid diagnostic test in around in a few years back, and that practice has been scaled across the country. Although this is not the best practice, I would say, but to enable early detection, rapid diagnostic tests definitely have a great role. The second part is the scaling of long-lasting insecticidal nets. Earlier, our country used to focus on insecticide-treated nets, which used to have a life cycle of only 6 months, or longevity of 6 months. However, the long-lasting insecticidal nets, in contrary, have a longevity of 3 years or 20 washes. And the Indian government have procured and distributed these nets to areas where the malaria incidence is more than 1 per 1,000 as a policy decision that was undertaken. And it was supported by the Global Fund to achieve this success in many areas, such as the northeastern region, 7 states in northeast, the state of Odisha, Jharkhand, Chhattisgarh, Madhya Pradesh, parts of Gujarat, parts of Maharashtra, and in some other states. However, there are opportunities to scale, and as I earlier mentioned, the major challenge remains with our notification policy implementation part, which is not happening properly. The second challenge remains with our approach to diagnose malaria. We still rely on tools which are less sensitive, like microscopy and conventional RDT. Third, we still rely on siloed practices at the government and private sector. The policy and the guidelines need to be disseminated to the private sector at the earliest. And finally, at the policy level, an urgent need is there to promote the innovation pipeline related to drugs, diagnostics, and insecticides, because in many different parts of the world, some tools are being used which we still don't have access to.
Yes, thank you. Thank you for the clarification. Another thing, there may be a doubt or some kind of questions from the juniors along with the general physicians altogether. The WHO has given the approval for malaria vaccine.
Right.
Is India is quite eligible, or there is any need of malaria vaccine in India?
See,
What is
the
your opinion?
malaria vaccine is not a new tool per se. So globally, research is happening for the almost last 30 years or even more than that to develop a malaria vaccine which is effective. If you see the current malaria vaccine, it focuses on very high endemic areas, Plasmodium falciparum predominant areas, and in child cases. But if you see the epidemiology of malaria in India, we have a fairly equal or proportionate distribution of malaria across different age categories. India is not similar in terms of epidemiology to the African countries, where the API is way more higher, or total positivity rate is way more higher than in India. And the third issue is that this vaccine has limited effectiveness, for which, if you think of the cost effectiveness part, investing in malaria vaccine and investing in other different solutions, such as the long-lasting insecticidal nets, the indoor residual spraying, the better diagnostics, mass screening, and other strategies, which are also cost-intensive strategies, but those strategies have more near-term impact compared to the vaccine, given the epidemiological setting that our country has. Having said that, there are at least more than 15 different candidate vaccines which are being tested and tried. And I am aware that at least one malaria vaccine is currently being tested, which focuses on multiple different stages of malaria. If such vaccines are available, I believe there will be more effectiveness in terms of applying vaccines. And also, other technologies such as monoclonal antibodies are coming up. Earlier last year, monoclonal antibodies were tried with promising results. So these two tools can later be effective, but it requires a lot of research, and India has only 5 years to eliminate malaria.
Very informative for all of us, and I think most of the doubts have been already cleared. So my last question for you for this session, sir, if we want to get this elimination as soon as possible, we can achieve it. But you know that from your presentation we can understand that we can achieve it. But how organization or like how an organization like IMA, you have already mentioned though that IMA can involve in this elimination program, as well as there are such several associations, including the general practitioners. So where their role can be light, and secondly, what kind of actions can IMA take to help the government to get the elimination? Please.
Right. So first is the opportunity part. Second is the actionable element part. So when I talk about elimination, I talk about three levels: policy, practice, and public. Fortunately, and this is a very great aspect, that the Indian Medical Association has strong voice in all the three different levels. At the policy level, as I mentioned earlier, India's last update on the guidelines for malaria diagnosis and treatment happened around 2013-14. India launched its malaria elimination campaign in 2016, following the Honorable Prime Minister pledge to eliminate malaria by 2030 in 2015's East Asia Summit. There is an urgent need to review the diagnosis and treatment guidelines and find out the existing gaps related to early detection, treatment completion, therapeutic efficacies, pharmacovigilance, and many other aspects which are trivial but becomes critical when it comes to eliminating malaria. For example, in our country, the formulation that is used for the treatment of pediatric or infant malaria, that is not suitable for infants. Similarly, better treatments are required for radical treatment. All these issues need to be addressed at the policy level, where IMA has a very strong voice. IMA has played very critical role during the COVID-19 pandemic, and it has essentially made many discourses that led to disruptive policy decisions that helped the country achieve early containment of the COVID-19 pandemic. Right now, IMA needs to have a very strong voice for malaria elimination. The second part, related to the practice level, is the practicing physicians who are currently working. They also have the responsibility and accountability to notify malaria cases. Once malaria cases get notified to the local public health department, then only actual action based on malaria incidents can be undertaken. If you see India's national strategic plan, all the anti-malarial interventions are tailored to malaria incidents. However, if we don't know the actual incidents, we can't tailor those interventions properly. So precision programming requires active participation, and with IMA's directory and membership of so many medical practitioners and physicians, it is possible to mobilize the private practitioners, the general physicians, to notify malaria and also align with the guidelines for malaria testing and treatment. The third piece that I understand here is the integrated management of febrile illnesses. See, COVID-19, malaria, enteric fever, dengue, and many other illnesses in the country which are posing health security challenges. The cardinal symptom is fever, and the patient comes to doctor with only fever and associated symptoms. When a patient is coming to the practitioner for fever, there need to be an integrated policy for managing all the febrile illnesses. The country has a provision for integrated management under the IDSP, Integrated Disease Surveillance Project or Program. However, at the private sector and also at the government sector, there is an urgent need to integrated fever management. Lastly, at the public level, so I talked about policy and practice. Lastly, at the public level, the interface between public and the doctors is the point where communication, health education happens the best. We have to accept the fact that still, despite many different issues related to patient-doctor relationship in this country, the reliance of the patient still is there on doctors' voices and doctors' key messages. The health education the doctor can provide, no one else can provide. So India Medical Association can proactively drive their members to drive those health education messages and key messages, which program the national program has been trying to deliver for so long time. The non-profit organizations and the partners are trying. So all these three levels of areas, we need Indian Medical Association's action, and through their members and through their leadership, both at the policy and practice level and also at the communications level with the patients.
Thank you so much for this excellent clarification. Rather, I think it will show the path towards the elimination for IMA, the organizations like IMA. We have few more questions. If Venkatesh allow me, we can have. Yes. So there is a tricky question: the TB versus malaria elimination from Muhammad Kasif, which is more challenging? Dr. Shorkar, if you answer it very briefly, whether this elimination of malaria is we are progressing faster than the elimination of tuberculosis. What's your opinion?
I would make a tricky answer as well. So just compare the number of countries that have eliminated tuberculosis and malaria in the past.
Exactly.
You'll get the answer. And another response is that, you know, we all know, who have learned epidemiology, we all know that eliminating an acute illness is way more easier than eliminating a chronic illness. Both are very difficult. Both
Exactly.
are longest standing diseases in the country. However, I believe the feasibility of malaria elimination is more than the feasibility of tuberculosis elimination, while the country's target is different.
Yes.
Based on various other factors.
Yeah. So the last one is what's your take on drug resistance malaria? It is by Dr. Pavitra M. Another
Right.
one from Dr. Arihan Chen. The 6 maximum malaria cases. Okay, the malaria cases are more in tribal, forest, and terrain regions. So, how do we tackle to control them, along with preserving their culture? Okay,
Right.
so these two questions. Yeah, please.
So first of all, drug resistance malaria, if you see the World Malaria Report 2021 and the recently published studies on therapeutic efficacies, although there are a lot of discussion around emerging mutations that promote drug resistance, treatment failure, which is the primary factor or which should concern the public health managers and the doctors, we have noticed that only in the northeastern region of the country. And accordingly, the Indian government allowed the use of artesunate combination therapy with artesunate lumefantrine combination in the northeast and artesunate sulfadoxine pyrimethamine combination in the rest of the country. Just to, for the sake of interest, because I have noticed during my review also that many different practices happen in terms of malaria treatment, we should provide chloroquine and primaquine for Plasmodium vivax, uncomplicated Plasmodium vivax, and in patients with who are not infant or pregnant women. And we should provide artesunate combination therapy to Plasmodium falciparum malaria cases. Injectable artesunate monotherapy is banned in the country. It should not be used. It promotes drug resistance. Chloroquine for Plasmodium vivax and ACT for Plasmodium falciparum is still very, very sensitive, and we don't have any reports yet from credible organizations related to resistance to these drugs. Please note that there are not many reserved drugs to fight malaria. Use these drugs cautiously and as per the National Treatment Guideline 2013.
Yes, and the second one?
The second one is related to the tribal, forest, and terrain areas. See, 80% of malaria occurs in these areas, tribal, forest, terrain areas. And the primary reason is that these areas are marginalized and inaccessible, receive limited services. At the same time, there is vector abundance, and you can't actually cut down the exposure to malaria from infected vectors much in these areas. So at best, what can be done in these areas is to improve access. If you see some of the best cases that has happened in this country, in the northeastern region, in the state of Odisha, some parts of Chhattisgarh, and in other states like Madhya Pradesh, they have tackled these problems with different strategies. The first one is, if you can't strengthen the routine surveillance in a surveillance dark area in a forest and hilly areas or areas with shifting cultivators, just focus on focal screening and treatment. Camp-based screening of a population, and treatment. Active surveillance becomes the mainstay of malaria control. In these, active surveillance and management remains the mainstay. In these areas, you can't rely on ASHAs because you can't expect the patient to travel 10-15 kilometers through the forest to reach to the ASHA's house to report his or her malaria. So when the patient cannot come to the health facility or the health worker, it is the responsibility of the health system to reach to the doorstep of the patient, and that's the mechanism of active surveillance. So there is an urgent need of active surveillance. The second is, in these areas there are a lot of reliance on unqualified medical practitioners, and they practice indiscriminately, and because of those practices, what happens is there are increased risk of anti-malarial resistance. Often patients are not properly treated, diagnosed, and even unknown deaths happen. So in these areas, there is an urgent need to apply the General Physicians Network of Indian Medical Association and promote this particular network at the small districts or sub-district level, so that this particular network can actually manage the large bulk of fever cases in these areas. Once that happens, the patient will get quality treatment. If some areas are truly inaccessible, we need to activate volunteers. For those, you need to identify local tribal people who can be trained, and these capacity building initiatives can be undertaken by the local physicians or the groups of local physicians, and also IMS district level units.